Good afternoon, everyone. My name is Vijay Patel, a pediatric otolaryngologist and rhinologist at Rady Children's Hospital in UCSD. And today I'll be talking a little bit about basilar invagination and Chiari malformation with a specific focus on endoscopic techniques endonasally through the nose. So as we know, there's been a rapid evolution in management of the craniovertebral junction in the last 20 years. And this really is a testament to the collaboration between the neurosurgical as well as the ENT disciplines. And this really was in its infancy, starting from as simple as performing pituitary surgery, and this is now an extension to very, very advanced approaches to accessing the C1, C2 area. And today, this talk is really a primer to think about some of the endoscopic management of Chiari malformation and really some of the treatment outcomes that are sort of early in the last 5 to 10 years. So as we know from the early data in the 1990s, the incidence of a retroflex odontoid could be as high as 26%. And the incidence of basilar invagination or radiographic imaging could be as high as 12%. And really, in more recent data in 2010, the incidence could be as high as 35% for our Chiari type 1 patients. So something we do see with quite some frequency. As we all are familiar with the classic signs and symptoms associated with Chiari, this could either be rapid in nature or very insidious. We know about the neck pain, the tussive headache, as well as some of the more advanced symptoms, which include cranial neuropathies, long tract signs, brainstem dysfunction, as well as myelopathy. So we're all familiar with this sort of radiographic image. We classically use the tip of the Bayesian, a line that's drawn from there to the most caudal point of the occipital curve. And when you have tonsil herniation more than 5 millimeters, this is what's sort of classically associated with Chiari type 1. So taking the same sort of idea one step further, when we diagnose basilar invagination in our patients with the appropriate signs and symptoms, we're utilizing both CT and MRI sequences, whether it be in the coronal plane or the sagittal plane, to see what is the exact degree of odontoid peg compression of the brainstem. And this is what we often use in addition to signs and symptoms to determine whether a patient's a candidate for a procedure. So thinking about if we have a patient that is a candidate for ventral decompression, there's sort of traditionally 2 approaches that we think about. Historically speaking, in the last 30 to 40 years, really it's been the Transoral approach that we use to decompress from the anterior corridor. But now in the last 10 years or so, there's really been an explosion in thinking about, well, what if we go through the endonasal corridor to address C1, C2 pathology? And this is really an exciting change in the last 5 to 10 years. So first, speaking to the Transole approach, this has been around since the 1960s. Initially it was done for antilaxial dislocation as well as cervical TB, but as you can imagine, going through the mouth, depending on the patient's degree of exposure, you'd have very limited access to the C1, C2 complex. And the incidence of postoperative complications were quite high. And this includes CSF leak, postoperative bleeding from the mouth, infection, and even in some cases, mortality. So advancements over a period of decades had led to significant improvements in the technique as well as application to both basilar invagination as well as Chiari type 1. But even in larger series of 20 plus patients at UCSF, we still saw some non-neurological related complications, which include swallowing defects, bleeding, significant swelling of the mouth after surgery requiring reintubation or tracheotomy, and postoperative infections such as meningitis or aspiration pneumonia. So when we looked at, patients over, 20, 30 years, we're talking over 1,000 patients, we actually saw the incidence of non-neurologic complications to be quite significant. This includes a 15% incidence of airway obstruction, whether that's reintubation or tracheotomy. The incidence of an infection, whether it be postoperative CSF leak or meningitis, could be as high as 10 to 15%. And this is because the bacteria in our mouth are just infinitely more pathogenic than the bacteria in our nose. And then in addition, since a lot of times to get appropriate access to the C1, C2 area, a lot of patients require to have a split of that soft palate area, and that leads to postoperative swallowing issues, dysphonia or dysarticulation issues, as well as swallowing problems where some patients are actually dependent after this approach. And historically, even there has been some reports of vascular injury as well as mortality related to this as well. So this really required sort of innovation to really understand, well, what else can we do? And sometimes if you can't get appropriate exposure to the mouth, you have to not only do the palpable split, you may have to remove the patient's tonsils and adenoids, which is something we commonly do in children. You may have to mobilize the craniofacial skeleton to get adequate access. You may have to even split the mandible. So this really made us think in terms of, well, what else can we do to offer our patients a more naturally minimally invasive corridor to address ventral compressive symptoms? And it was in 2005, and I was super fortunate to train at Pittsburgh with Dr. Steinerman and Dr. Gardner, who really first described endonasal decompression of the foramen magnum. And really in their series, what they demonstrated was a shorter length of stay with increased patient satisfaction. And the reason why is you naturally use your technical skills when it comes to endoscopy And you're able to see everything in terms of the arch of C1, C2. You get ability to work together with your neurosurgery colleagues and really can see exactly what you're decompressing in this area. And following surgery, many of these patients do quite well. They're able to feed immediately after surgery. There's no airway concern. So a lot of positive that kind of came out from this initial data. And then as we sort of understood this pathology over the last several years, they sort of published their series on this to understand, well, how can we predict which patients are the best possible candidates for a anterior decompression? And really, there's a line that we describe, which is called the Nasopalatine Line. You draw a line from the inferior aspect of the nasal bone, go to the hard palate, and that will show you how low you can get to the C1, C2 area. And universally, for all patients that have basilar invagination, you're able to get within 1 centimeter of the C2 base. So really, the vast majority of patients, if they are a candidate for anterior decompression, it can be done endonasally. And another nice little trick that you can have is when you're positioning the patient in the operating room asleep, when you pin these patients on a Mayfield, a little bit of cervical flexion, if that's allowed by SSCPs, will allow you to even get within another centimeter and a half inferiorly. So this is sort of a nice little technique because we know that patients' anatomy can vary from case to case as well. When it comes to our Chiari patients, Dr. Gardner published his series on children in 2010, where he described patients that had headaches, dysphagia, myelopathy, scoliosis, and their algorithm at Pittsburgh was to perform an anterior decompression as well as a posterior decompression with an OC fusion. And these patients actually did quite well with improvement of their neurological symptoms and no complications following surgery. So, and you can really see why the endonasal corridor is so appropriate. These are sort of cadaveric photos that kind of show what you can really see endonasally. And this is just a view of the back of the nose, and sort of the red dotted lines on the left of the screen really shows that tissue that you can elevate to expose the cervical spine. And once you do that, you see the anterior occipital membrane that's resected, you see the arch of C1, you see the dens, and you can really do a tailored odontodectomy to really decompress that sort of ventral brainstem compression. So this is actually one of the cases that I did a couple of years ago at Pittsburgh. This was a 59-year-old male that had a history of basilar invagination. This was secondary to rheumatoid arthritis, and he was sort of managed with biologic therapy as well as prednisone. And he had seen multiple neurosurgeons across the country who had universally recommended haloarthrosis followed by fusion. You'll see why when you see this patient's preoperative CT and MRI scans here. And you can see really the degree of the odontoid pit compression along the brainstem, whether it be the coronal sequence or the sagittal sequence. And when you look at the patient's preoperative CT scan, you'll also see no matter what criteria you use, whether it's the coronal plane or the sagittal plane, this patient meets criteria indefinitely for basilar invagination. And the purple line really shows you how low you can get through the endonasal corridor as far as the inferior extent of C2. So this patient was an excellent candidate for anterior decompression. So this is a little video that sort of demonstrates the technique here that we performed at Pittsburgh. And basically, the first step really is when you're providing endonasal access is outfracturing the inferior turbinates. Sorry, technical difficulties. So the first step is once you're inside the nose, you outfracture the middle turbinates and the inferior turbinates to preserve that tissue. And then the next step really is you make these L-shaped incisions along the nasal septum so you can preserve that mucosa, and then resect the posterior part of the septum so you have binaural access to the nose for the neurosurgeons. And once you do this, it's really easy to see the access that you achieve along the posterior nasopharyngeal area. And then once you remove any redundant tissue that's sort of blocking your view in an unobstructed fashion, then you can go ahead and perform the next step of the procedure, which is really drilling down this maxillary crest. This is just the floor of the hard palate, so you can really reach inferiorly to the base of C2 when you need to complete your endonasal decompression. Once this is done, then you go ahead and expose the superior limit, which is the sphenoidotomies that you do on each side. And once you do this, you can drill down the sphenoid keel and then go ahead and raise that rhinopharyngeal flap, which will be used to reconstruct the anterior spine after you're done with your decompression. And this is what's done, and it's very easy to raise this rhinopharyngeal flap. You just use a needle tip bovicautery. And once this is done, you expose the entire C1, C2 complex, and you can often utilize neuronavigation to confirm that this is actually present. And once this is done, then you go ahead and first drill the inferior third of the clivus, and you basically drill this flush to the dura, the periosteal layer. And then once you have that done, then you'll expose the atlanto-occipital membrane, and then you can expose the arch of C1, and then the dens, which is C2. And then you try to preserve at least 50% of the arch of C1 to minimize any potential instability. And then once you can see the tip of the dens, you just go ahead and start to drill that sort of from superior to inferior until you kind of have a complete decompression. And a lot of times, a lot of these bony fragments are really adhered to some of the ligaments and things like that. So you're just very gently removing one piece at a time. And once you do that and you have the whole odontoid totally resected, then you'll have basically your posterior limited section, which is the tectoral membrane, and you want to preserve that because if you do that accurately and very precisely, you can avoid a CSF leak completely when you're doing this approach. And once this is done, then all you have to do is use your neuronavigation and check to see if you have an adequate decompression of the entire anterior brainstem. And once that's done, you've really completed the entire surgery, and then you can proceed with reconstruction. So here we're just removing a few more fragments of bone, and once that's done, we'll check with navigation to make sure we really removed everything off the tectoral membrane here. And as you can see, it's often tenacious. You have to sort of take your time, be very patient, and once you sort of get everything out, you check here, and this is the navigation probe going in, and you're checking posteriorly, superiorly, and laterally to make sure you've appropriately resected as much bone as possible. And then once this is done, you can go ahead and reconstruct. Basically, you use that rhinopharyngeal flap that you elevated up front, put that back up, you use a little bit of tissue glue to hold that in place, and then you go ahead and put your septum back down where it was on each side, and then put a little bit of packing behind the back of the nose so there's no drainage after surgery. And a lot of times, if a posterior fusion is indicated, you go ahead and do that, and you can flip the patient prone, and then your spine surgeon can come in and sort of take care of that part of the surgery. And you can really see how successful this is. This is the postoperative CT scan for this patient. You can see you've completely resected the peg of the odontoid, you preserved the arch of C1, and you can see the interval OC fusion that's also been done for this particular patient as well. So looking at what it takes to develop an endoscopic approach, initially there's obviously going to be a little bit of struggle in terms of learning how to do this type of surgery. It took over 10 hours in the early 2000s for the Pittsburgh group to really understand how to do this, and this has been cut down in the last 10 plus years to a 3-4 hour surgery, such that if you need to do a sort of combined surgery, which is the endoscopic anterior decompression as well as the posterior fusion, you could do that all in one operative session, which we've done many times. Looking at the data now in terms of, well, what is the outcomes for anterior posterior decompression for our, Chiari patients? So this is a recent paper out of Cornell looking at 42 patients that had either basilar invagination or type 1 Chiari, and they were all undergoing the same treatment protocol, which included endonasal odontodectomy, suboccipital decompression, as well as posterior OC fusion. All these patients were able to be extubated at the end of the case, be able to feed within 1 day after surgery, no instances of CSF leak or meningitis, with a follow-up for approximately 3 years. The neurologic outcomes for many of these patients was quite good, 98% improvement following surgery, and we know, at least when you compared the preoperative MRI to the postoperative MRI, that you have increased T2 signal or CSF space in the ventral brainstem, which is the marker of a successful surgery. Looking at kids, a similar study was done where most of these patients actually were Chiari patients, same treatment protocol. Most of these patients were extubated the same day after surgery, were able to feed immediately after surgery, no instances of CSF leak meningitis, with almost a 3-year follow-up, improvement in the Rankin scores, which is the functional score for these patients following surgery, and similarly improved CSF signal in the ventral brainstem following surgery. So, reassuring data as far as, consideration of both an anterior and posterior decompression. So outside of the objective data when it comes to success of surgery, these are actually some more interesting data with regards to quality of life studies for Chiari patients. And basically they surveyed patients, and what they wanted to ask was, what was your overall improvement in terms of undergoing endoscopic nasal approach for anterior decompression? And almost 80% reported subjective improvement with minimal sinus morbidity. And on the quality of life surveys, whether it be role functioning, emotional well-being, pain, they all had reported significantly positive outcomes in that regard. So looking at it sort of head-to-head, sort of transoral versus endonasal. So Pablo Ricinos out of Cleveland Clinic, he's a skull-based surgeon, he looked at both the transoral versus the endonasal approach to see, well, is there a difference between the two techniques, whether it be neurologic outcomes or complications? And what they found is that, if anything, they're comparable. Obviously, there is a significantly larger N when it comes to the transoral approaches because it's been going on for decades, whereas the endonasal approach is really something within the last 5 to 10 years. But what we did see from a complication profile standpoint is that there's a 10-fold incidence of needing a tracheotomy following a transoral approach. So, one positive fact when it comes to thinking about the endonasal corridor as a way to avoid that for our patients. So the other thing that's really come to a head is really understanding the way the biomechanics works of C1, C2, and what we found more recently through the Cincinnati group is they also did a meta-analysis of 462 patients that either had Chiari or Basilar Invagination. Whether you undergo a transoral approach or endoscopic approach, if you're able to preserve any part of the arch of C1, ideally 50% or more. That's a significant change in terms of the ability to preserve that cervical spine structure and maybe even potentially avoid the need for posterior fusion, at least for the anterior decompression component. Because right now, many of these patients need to have the anterior decompression as well as the posterior fusion. So, looking at this sort of from a mile high perspective, really my goal today is just to at least introduce the idea that there's something else besides what's always been done for many patients over the last 20, 30 years in terms of thinking about anterior decompression, whether it's part of your initial surgery or part of your, well, we had some success with the posterior decompression, but now we're still having symptoms. What else can be done? Really, the anterior corridor may be something that may be worthwhile. And there's a lot of advantages that comes with the anterior transnasal corridor compared to the transoral corridor. So, in summary, really, we do see ventral compression a lot of the time in Chiari type 1, and really, endoscopic adontodectomy plus or minus fusion, when it's indicated, really is a treatment of choice, at least in the modern era, for irreducible ventral brainstem compression. And some of the advantages of the endoscopic approach includes dynamic visualization, improved patient tolerance, prompt oral feeding after surgery, and minimal airway problems after surgery for our patients as well. And at least per some of the systematic review data, endonasal approaches at least appear to be comparable to transoral approaches, not only when it comes to neurologic outcomes, but maybe even arguably a reduced complication profile. And certainly, further and additional research needs to be done, hopefully in an ideally multi-institutional fashion, to really look at the durability of surgical outcomes beyond 3, 5, 10 years for our Chiari patients. With that, I'd like to thank my mentors at the University of Pittsburgh as well as CHLA, where I trained. Wouldn't be here without their support and their dedication. Thank you all.